Sayın Rektörüm, değerli Atlas Üniversitesi ailesi, değerli bilim insanı Doktor DeFronzo'ya Oditoryumumuzun isminin verilmesi ve bu kapsamda Doktor DeFronzo tarafından verilecek seminere hoş geldiniz. Şimdi açılış konuşmalarını yapmak üzere Rektör Vekilimiz Prof. Doktor Engin Gülal'ı kürsüye davet ediyorum.
Sayın Başkanım, üniversitemizin değerli mensupları, kıymetli misafirler ve sevgili öğrenciler, öncelikle hepinizi saygı ve sevgiyle selamlıyorum. Bugün sağlık konusunu ele alacağız ve sağlıkta önemli bir yeri olan diyabeti konuşacağız. Diyabetle ilgili en güncel bilgileri konunun uzmanı olan Doktor DeFronzo'dan dinleyeceğiz. Davetimizi kabul edip bugün aramızda olan Sayın Doktor DeFronzo'ya özellikle teşekkür ediyorum. Değerli konuklar, sağlık sadece hastalık veya sakatlığın olma işi değil, sağlık kişinin bedenen, ruhen ve sosyal yönden tam iyi olma hali olarak tanımlanmaktadır. Sağlık ile beslenme arasında doğru bir korelasyon olduğu bilinmektedir. Tükettiğimiz yiyeceklerimizin sağlığımız ve yaşam kalitemiz üzerinde çok büyük etkisi olduğu, ciddi hastalıklar ile kötü beslenme arasındaki ilişki yapılan birçok çalışmada ifade edilmiştir. Sağlıklı beslenme ile kalp hastalıkları, diyabet, hipertansiyon gibi hastalıkların önlenebildiği veya geciktirilebildiği sağlık otoriteleri tarafından toplumla da paylaşılmaktadır. Kronik hastalıkların tüm dünyada ve ülkemizde ölüm nedenleri arasında ilk sırada yer aldığı ve diyabetin organ kayıplarına yol açan, yaşam kalitesini de olumsuz yönde etkileyen kronik bir hastalık olduğu bilinmektedir. Uluslararası Diyabet Federasyonu dünya genelinde yaklaşık 400 milyon diyabet hastası olduğunu tahmin etmektedir. 800 milyar dolar ile küresel sağlık harcamalarının %10'u da diyabete harcanmaktadır. Yaşlanan nüfus, kentleşme ve değişen yaşam tarzı ile diyabet de hızla artmaktadır. 2050 yılında dünya genelinde diyabetli hasta sayısının 1 milyarı aşacağı tahmin edilmektedir. Bu konudaki güncel bilgileri belki bizle Doktor DeFronzo da paylaşacaktır. Türkiye'de ise yaklaşık 7 milyon yetişkin diyabet hastası olduğu tahmin edilmekte ve diyabete yönelik harcamalar ülkemizde ise toplam sağlık harcamalarının %25'ini oluşturmaktadır. 2045 yılında Türkiye'de 10 milyondan fazla diyabetli hasta olacağı ve ülkemizin diyabetin en sık görüldüğü ilk 10 ülke arasında yer alacağı öngörülmektedir. Değerli konuklar, sağlık alanında yürüttüğümüz faaliyetlerle öne çıkan üniversitemizin diyabetle alanıyla da ilgili olarak tıp fakültemizde endokrinoloji ve metabolizma hastalıkları bilim dalında, diyabetli hastalıkların beslenmesiyle ilgili olarak beslenme ve diyetetik bölümümüzde, tanı konmuş hastaların çok boyutlu tedavisi ve bakım süreciyle ilgili olarak da hemşirelik bölümümüzde çeşitli çalışmalar yürütülmektedir. Değerli bilim insanı Doktor DeFronzo ve ekibiyle gerçekleştireceğimiz ortak çalışmalar ve kuracağımız güçlü işbirliğiyle üniversitemizde diyabet konusunda yürütülen çalışmalara güç katacaktır. Doktor DeFronzo'yu üniversitemizde görmekten memnuniyet duyduğumuzu ifade ederek bugünkü yapacağımız çalıştayın verimli geçmesini temenni ediyorum. Konuşmamın sonunda diyabetin universal sembolü olan mavi çemberin dışında kalalım diyerek selam ve saygılarımı sunuyorum efendim. Değerli konuklar, Doktor DeFronzo'yu sunumu için, konuşması için davet etmeden önce kendisinin özgeçmişini sizlerle de paylaşmak istiyorum. Oldukça uzun bir özgeçmişti. Mümkün olduğunca özetlemeye çalıştım ama o bile bayağı bir yer kaplıyor. Doktor DeFronzo, Yale Üniversitesi'nde biyoloji ve biyokimya eğitimi aldıktan sonra Harvard Tıp Fakültesinden mezun olmuştur. John Hopkins iç hastalıkları eğitimini tamamlamasının ardından endokrinoloji ve nefroloji alanında Baltimore City Hastanesi'nde, Pennsylvania Üniversite Hastanesi'nde çalışmalarını sürdürmüştür. Doktor DeFronzo 1988 yılından itibaren de Teksas Üniversitesi Diyabet Bölüm Başkanlığı görevini yürütmektedir. Doktor DeFronzo özellikle son 50 yıl içinde diyabetle ilgili birçok önemli çalışmanın içerisinde de yer almıştır kendileri. İnsülin direnci kavramının geliştirilmesinde öncü bir rol oynamış ve bu kavram tip 2 diyabetin tanımlayıcı özelliği haline gelmiştir. Doktor DeFronzo, metformin adlı diyabet tedavisi ilacının Amerika'daki gelişimini yönetmiş. İlaç FDA onayını 1995 yılında almıştır. Doktor DeFronzo'ya yaptığı çalışmalar nedeniyle de birçok ödüle layık görülmüştür. Ben bu ödüllerden bazılarını sizlerle paylaşmak isterim. Amerikan Diyabet Derneği tarafından 1987 yılında Lilly ödülü, 2002 yılında kendisinin 200'den fazla genç araştırmacının eğitimlerine katkılarından dolayı Albert Reynolds ödülünü, 2005 yılında yaptığı klinik araştırmalardan dolayı Novartis ödülünü ve 2008 yılında da Banting ödülünü almıştır Doktor DeFronzo. Yine Avrupa'daki yapılan Diyabet Araştırma Derneği tarafından ise kendisine 2008 yılında Clyde Bernard ödülü verilmiştir ve 2017 yılında hem Amerikan Diyabet Derneği ve Avrupa Diyabet Derneği tarafından verilen en yüksek bilimsel ödüllerden biri olan Harold Ham Diyabet Biyomedikal Araştırmalar Uluslararası Ödülü kendine tevdi edilmiştir. Ayrıca Doktor DeFronzo'nun 800'den fazla da bilimsel yayını bulunmaktadır. Şimdi de değerli bilim insanı Doktor DeFronzo'yu konuşmaları için kürsüye davet ediyorum.
Okay. Very good. Good morning to all of the deans from the various schools who are here, to all of the faculty, and most importantly to the students, because the students really are the heartbeat of any institution. So before I start my formal talk, I want to really give thanks for the honor of having this auditorium dedicated to me. That picture that you saw earlier was a picture from about 30 years ago. I'm told that I really haven't changed very much. So that means now that I've been here and this auditorium is named after me, I expect to come back for another 30 years every year to meet with the faculty and the students. I think you as students are very, very lucky. This is a wonderful institution. It's brand new. You are going to have a great career as you go forward in medicine. And I hope that some of you, at least, will come and visit us and spend some time in San Antonio, Texas. Turkey is a beautiful country. I've been here many, many times. But I would like to extend an invitation to all of you to come and do some of your rotations in San Antonio. The people in San Antonio are very much like your people here. So I think you'll feel very, very comfortable. So I hope this is the start of at least another 30 years together of my coming to visit you and you coming to visit me. And for the students, the one thing that I can tell you is, because you're going to have many decisions to make as you go forward, you need to look into yourself and decide what it is that you want to do, not what it is that other people tell you you should do. So during my lifetime, I've been told many times that you're wrong, you shouldn't do this, and you shouldn't do that. I have persisted. I'd like to tell you that I have been wrong at least once, but I have never been wrong because I listened to myself. So to the students, I would say the same thing. Pursue what is in your heart, and you will be successful. Okay, enough for the introduction. I'm going to talk to you about diabetes. Diabetes is a big problem. It's a big problem in the United States. It's a big problem here in Turkey. It's a big problem worldwide. And these are data from the United States, but I can assure you, you have the same kind of problems here. So if we look at diabetes, these are the complications that occur every day, not every week, not every month. There are 4,000 new cases of diabetes who are diagnosed every day in the United States. Every day, 800 people approximately die every day from diabetes. Diabetes is actually a much, much bigger problem than is cancer. Yet we spend much more money in cancer research than we do in diabetes research. There are 230 amputations every day. There are 120 individuals every day who end up going on to dialysis, and 55 people who go blind every day. So you can see that this really is a monumental problem. And when you understand that this is what happens every day, you can see it's a huge problem. So diabetic patients, to take care of them, takes a lot of time. It's a disease that takes its toll in terms of quality of life on the diabetic patients, and it's very expensive. Now, the good part of the story is that we actually now have medications along with lifestyle intervention that really can make life much better for our diabetic patients. But we still have a long way to go. So what I've plotted for you here is as a function of time, starting from year 2000 to the present, how well we're doing in terms of controlling the hemoglobin A1C. So the hemoglobin A1C is what gives us an index of the mean glucose control over the 2 to 3 months in which we see the patient. And that's the index that we use to gauge how well we're doing. So the white line is how many people have a hemoglobin A1C that's less than 7 or above 7. And you can see that 50% of the people are above that white line. And if you look at the yellow line, that's the percentage of people with a hemoglobin A1C that's above 8. And 25% of the people have a hemoglobin A1C that's above 8. So the simple fact is, even though we have very good medicines and we know how to treat our diabetic patients, we still don't do a very good job in getting the A1C controlled. And that level of hemoglobin A1C is going to determine who's going to go blind, who's going to end up on dialysis, and yet we still have a long way to go. So why do we not achieve these goals? There are a number of reasons. So at the top of the list, I put the treat to fail approach. So what we've done in the past is we see a newly diagnosed diabetic patient, and we start them on the first drug. The first drug usually is metformin. I like metformin. I brought it single-handedly to the United States, but we have many, many better drugs than metformin. And I'll show you that even though it's a good drug, with time, you're going to fail. So then we add the second drug. Your A1C comes down, it rises. The second drug is usually a sulfonylurea. And like metformin, the sulfonylureas are not going to work on a long-term basis. You fail, we add a third drug. And we're always playing catch-up rather than being aggressively and treating more from the beginning. Physician inertia is a big problem. Physicians see the hemoglobin A1C come back. They can see it's elevated, and it takes sometimes many years for them to change the medication or add new medications for the treatment of our diabetic patients. The patients themselves can be a problem. So we rely very heavily on our dietitians and our nurse educators because the patient needs to understand what we as physicians are trying to do. And quite frankly, we as physicians oftentimes don't have the time that is required to spend with the patients. So in my life, the nurse educators and the dietitians are actually more important than are the physicians, because they're the ones that actually are speaking to the patients. So if you fall and you break your ankle, it hurts. You go to see the doctor immediately. But for diabetics, the damage is taking place in the eyes, the kidneys, and the arteries. There's no pain. So it's difficult to convince a patient to do something today that's going to make a difference 20 years from now when the patient can't feel that something has gone wrong in the body. The newer medications are fantastic medications, as I will take you through them, but they're very, very costly. So I'm going to talk to you about the glucagon-like peptide-1 receptor agonist. These are the newer classes of drugs, and they are really outstanding. But the most recent one introduced to the U.S., which is called Mounjaro, cost $1,200 per month. So if you multiply that by 12 months, that's $30,000 to $40,000. So although the newer medications are phenomenal, they're also very expensive. And then lastly, and perhaps most importantly, is that diabetes is a very complex disease from the pathophysiologic standpoint. And if we don't use medications to correct the underlying pathophysiology, we're never going to get our diabetic patients control. So when I gave the Lilly lecture, that picture was taken in 1985 that you saw earlier. And it was taken at the time that I gave the Lilly lecture. That was the Young Investigator Award. And I described the pathophysiology of type 2 diabetes with two simple words, the triumvirate. There are three problems that you need to take care of. So we know that there's insulin resistance, and the two organs that participate in this insulin resistance are the liver and the muscle. And we also know that there's progressive beta cell failure. So let me take a little bit of time to explain this in detail, because if you don't really understand what causes type 2 diabetes, you'll never understand how to treat it. So we go to sleep at night at 9 or 10 o'clock, and we wake up in the morning. And we go to sleep at night, our fasting glucose is 80. We wake up in the morning, our fasting glucose is still 80. Yet we haven't eaten anything throughout the sleeping hours. So it's critical that you keep your glucose at about 80 or 90 milligram per deciliter, because the brain can only utilize glucose. So where does that glucose come from that's being produced throughout the sleeping hours? It comes from the liver. Now, in the person with type 2 diabetes, the liver is resistant to insulin. This is an observation that we first made many, many years ago. And the liver overproduces glucose so that when a diabetic wakes up in the morning, they have an elevated fasting glucose. So we're going to need drugs that work on the liver to suppress hepatic glucose production. The diabetic now wakes up, they're going to have their breakfast, their lunch, and their dinner, and the glucose, the carbohydrate that's in the meal, needs to be taken up and disposed of in the muscle. But now the muscle is resistant to insulin, so we get an excessive rise in glucose above baseline, postprandial hyperglycemia. So we're going to need drugs that work on the muscle to improve insulin sensitivity. And then lastly, at the top, diabetes is characterized by progressive beta cell failure. This is the genetic component of the disease. So now as your beta cells start to fail and you secrete less insulin, that insulin resistance is present in the liver and the muscle, becomes quite manifest. And the diabetic, of course, is characterized by hyperglycemia. And this is what's causing the eye damage, the kidney damage, and the nerve damage. So in 1985, this was a very simple understanding of what caused type 2 diabetes. In 2008, I gave the Banting lecture at the American Diabetes Association, and I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So we had not 3 problems to deal with. We now have 8 problems to deal with. So as science progresses, we learn more and more about what it is that caused type 2 diabetes. So in the lower left, we still have the insulin resistance in the liver. In the lower right, we still have the insulin resistance in the muscle. In the upper left, the beta cell failure. But now we have to add 5 new players. So what's driving the epidemic of diabetes is the epidemic of obesity. We take in excess calories. Now, initially, those calories can be stored in the fat cell. And as long as the calories stay in the fat cell in the form of triglyceride, they can't hurt you. But as the fat cells expand, they become very resistant to insulin. And now you start to break down the triglycerides and you release into the bloodstream free fatty acids. Elevated free fatty acids cause insulin resistance in the liver, insulin resistance in the muscle, and progressive beta cell failure. So this defect at the level of the adipocyte is making those 3 components of the triumvirate progressively becoming worse. At the top is the gastrointestinal tract. The gut is a giant endocrine organ. And when you eat a meal, you're going to release two incretin hormones. We're going to come back and talk about them in more detail. GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulin-trophic polypeptide. These two incretin hormones are responsible for 70% of the insulin that you release in response to the meal. So what goes wrong in the person with type 2 diabetes is that your beta cells, those insulin-secreting cells, become very, very resistant to GLP-1 and GIP. And this leads to a deficiency of insulin, which of course leads to the progressive rise in glucose and A1C. At 9 o'clock is the alpha cell. The alpha cell in people with type 2 diabetes overproduces glucose, and it overproduces glucagon, and that elevated glucagon level works on the liver to drive the excess hepatic glucose production through the sleeping hours. So we're going to need medications that work to suppress glucagon secretion by the alpha cell. At 3 o'clock is the kidney. And many years ago, we showed that the kidney plays a very, very important role in the pathophysiology, but in a very special way. So in you or I, as our blood glucose level goes up, and it goes from 80 to 100 to 120 to 150 to 180, no glucose appears in the urine. But once your glucose gets to be 180, the glucose now spills out into the urine. Well, what we showed many, many years ago is that threshold for spilling glucose in the urine becomes markedly elevated. So instead of spilling glucose at 180, that threshold may be 240, 250, 260. So the kidney, instead of dumping the glucose in the urine, is holding on to it. And many years ago, I invented a new class of drugs called the SGLT2 inhibitors that block glucose reabsorption in the kidney. And these drugs have become one of the mainstays for treating people with type 2 diabetes. And we'll come back and talk about them in more detail. And then at the bottom is the brain. The brain plays a very important role in the pathophysiology of type 2 diabetes, but in a very, very different way. So when you eat a meal, at some point, you become satiated and you stop eating. Well, there are a number of hormones that are released in response to the meal that send a signal to your brain to stop eating. One of the very important ones is called GLP-1, glucagon-like peptide 1. That's the same one that works on your beta cells that cause you to secrete insulin. It's also one of the critical hormones that tells your brain to stop eating. Well, it turns out your brain has become resistant to GLP-1. It's also become resistant to amylin and a number of other molecules that are regulating appetite. So because your brain has become resistant to these appetite suppressant hormones, you overeat and you gain weight. And when you gain weight, your tissues in your body become very resistant to insulin. So diet therapy is something that's very, very difficult for our diabetic patients because they're very, very serious physiologic derangements that are forcing them to eat. And we don't take this into account. And that is why in the management of people who are type 2 diabetes, and 80 to 90% of these type 2 diabetic patients are overweight. In addition to lifestyle intervention, which is critically important, you're going to need pharmacologic therapy. And people need to understand that obesity is a disease. It's a disease that causes diabetes. It's a disease that causes cardiovascular disease. It's a disease that causes gallbladder disease, etc. So it's not so simple for the dietitian to tell the patient or the doctor to tell the patient, you need to just cut down on your caloric intake, because there are all these physiologic changes that are driving the patient to eat in excessive amounts. So when we think about the treatment of type 2 diabetes, if there are 8 problems, there's no way that one drug is going to correct 8 problems. So we're going to have to use multiple drugs in combination from the initial time of diagnosis. More importantly, when we pick a drug for our diabetic patients, we should be picking drugs that correct the underlying pathophysiology. If you simply pick a drug that lowers the glucose, on a long-term basis, it's not going to work. So at the top of the list of the drugs that don't work are the sulfonylurea drugs. Now, if you look in the United States, and I know this is also true for Turkey, it's true throughout the world, the first drug that's used is metformin. Well, in 1995, when I brought metformin to the United States, that was a great drug. Today, it's down in the bottom of the list of my good drugs. The second most commonly prescribed drug are the sulfonylureas. They don't correct any of the problems that are present in diabetics. And the third class of drugs in the list that are prescribed are the DPP-4 inhibitors. We'll talk about them. And they are very weak drugs. So the three most commonly prescribed drugs are the drugs that are going to be least effective in treating your diabetic patients. And I'll take you through this in more detail. And then we need to start early in the natural history of the disease, because with time, yes, the beta cells start to fail, but more important, the beta cells start to die. And as the beta cell mass drops, then of course, those are the cells that are responsible for secreting insulin. And if you don't preserve the number of beta cells, eventually your diabetic patients are going to have to go on to insulin therapy. And insulin therapy is not easy for our diabetic patients. So to illustrate these points, I would like to show you the data from the United Kingdom Prospective Diabetes Study. This is Dr. Robert Turner's study. This study started in 1990 to 2000. And this slide is taken directly from the Lancet publication. Now, Dr. Turner believed that if you took newly diagnosed type 2 diabetic patients with a starting hemoglobin A1C of 7, if you put them on a single oral agent, the A1C would come down and stay down. So in this study, there are about 4,200 patients. 1/3 of them got lifestyle intervention. Lifestyle intervention means dietary intervention and increase in physical activity. And you can see that yellow line went straight up in terms of the A1C. This was an old study, but it told us on a long-term basis, it's very difficult for patients to lose weight, maintain the weight loss, and to get onto an exercise program. And all of that rise in A1C was due to progressive beta cell failure. 1/3 of the patients got treated with glibenclamide. This is a sulfonylurea drug. Sulfonylurea drugs, they bind to the sulfonylurea receptor in the beta cell. They kick out insulin. And you can see in the first year, let's see, is this, just looking to see if I got a point. Yeah. I think you can see this. So in the first year, there's a nice drop in the A1C. But you can see what happens after the first year is a progressive rise in the A1C. So on a long-term basis, the sulfonylureas are not going to correct the defect that's level at the beta cell. And in fact, they don't correct any of the other 7 problems that are present in people with type 2 diabetes. So these drugs are destined to fail. If we look at metformin, which is the orange curve, metformin is not a true insulin sensitizing drug. Many professors do teach this to their students, but I assure you, we did the studies that were presented to the Food and Drug Administration, and using the gold standard technology for measuring insulin sensitivity, we never could show that metformin was an insulin sensitizing drug. Metformin works on the liver, and it shuts down that excess glucose production throughout the sleeping hours. So there's a nice drop in the A1C, but then you can see progressive beta cell failure. So Dr. Turner realized about 5 years into this study that the A1C level had come back to where he started. So he wrote 5 papers, and they're published in very prestigious diabetes journals: Diabetes, Diabetes Care, Diabetologia, Lancet, BMJ. And he said, my hypothesis is not correct. You cannot put people on a single oral agent and get the A1C to stay down. So if you're on metformin, he added glibenclamide. If you're on glibenclamide, he added metformin. And then he said, if necessary, I will add insulin. And if you look 15 years later, everybody is on glibenclamide and metformin. 65% of the people are on insulin, and the A1C is 8.6. So we knew 30 years ago that metformin sulfonylurea is simply not going to work. Yet, in every country in the world, including the United States, who's supposed to be the leader in diabetes care, we use metformin sulfonylurea DPP-4 inhibitor in insulin. We seem not to have learned from what Dr. Turner taught us. Now, the main reason why the United Kingdom prospective diabetes study was carried out had nothing to do with what medicines would work or not work. At this time, there was a great debate as to whether lowering the A1C made any difference in terms of eye, kidney, and nerve complications. So this study actually was designed to see if therapy with medications and more aggressive lowering of the A1C would decrease retinopathy, nephropathy, and neuropathy. And what this study showed for the very first time in type 2 diabetics was that 1% difference in A1C decreased eye, kidney, and nerve complications by 37%. So this was the primary aim of the study. But it was very clear from this study, it told us what medicines were going to work and were not going to work on a long-term basis. So I call this the 15-year revelation, okay? We seem not to learn from our mistakes. So Dr. Turner showed in 1990 that metformin sulfonylurea therapy was not going to work. What came 15 years later was the ADOPT study, which I'm going to show you, by Dr. Stephen Kahn. And he reproduced exactly what was seen in the United Kingdom prospective diabetes study and clearly showed that neither metformin nor sulfonylureas were going to work. So you think that we would have learned in 2005 that metformin sulfonylureas was not the best approach? Well, we had to do another study, 2015. So every 15 years, we reproduce the same mistakes that we made 15 years before. So I hope today we're not going to wait another 15 years and do the same stupid study, okay? So here now is the ADOPT study. This is Dr. Kahn's study. So we're going to plot the A1C on the y-axis as a function of time on the x-axis. Glyburide, sulfonylurea, and metformin. An initial drop in A1C, and then a progressive rise in A1C thereafter. And if you calculate the rate of failure, it's identical in the ADOPT study as it is in the UK PBS. So here's the GRADE study that was started in 2015 and just recently published in the New England Journal of Medicine. Now, to get into the GRADE study, and it's a big study, 5,000 people in the study, you had to have failed on metformin, okay? So by definition, metformin has failed, just like it does all of the time on a long-term basis. So they wanted to know, what is the best drug to add to metformin? So the white line is glimepiride, a sulfonylurea drug. So what happened with glimepiride? You can see an initial drop in A1C, but then look what happened. A progressive increase, just as we saw in UK PDS, just as we saw in the ADOPT site. Sitagliptin, a DPP-4 inhibitor, the third most commonly prescribed drug in the United States and in the world, and also here in Turkey. You can see exactly the same thing. A1C comes down and then progressive failure. Somewhat of a surprise, liraglutide is a GLP-1 receptor agonist. I actually thought that that would turn out to be the best medication, but it also failed. I do believe that the newer GLP-1 receptor agonist will actually take the A1C down and keep it down. And then glargine insulin. Insulin therapy is very difficult. The physicians tend not to titrate the insulin up rapidly enough. And you can see glargine insulin also failed. So the standard therapies that many of you as students are going to be taught, you need to remember what Dr. DeFronzo told you. They are not going to work, okay? The newer medications I will show you will work. The big problem is they're very expensive and they're not available to many of our patients. So any therapy is better than no therapy, okay? The better that you can control the A1C, even if it's on the less effective medicines, the better off you're going to be. So I'm going to come back to the ominous octet. And I'm going to show you for every medication that's available where they work. So here now, you can see that metformin works on the liver. It improves insulin sensitivity in the liver, not in the muscle. And it suppresses hepatic glucose production throughout the sleeping hours. Fasting glucose goes down. On a long-term basis, however, metformin fails. Now, what about the sulfonylurea drugs? Because you can see in the title, this is metformin and sulfonylureas. Dr. DeFronzo lost his speech for the first time in his life, right? No. Sulfonylureas don't work anywhere here. That's why he cannot say anything, okay? So these are the number 1, 2 drugs that are used everywhere in the world, including in the US, and they're really not very effective in treating our diabetic patients. Now, this is a class of drugs called the thiazolidinediones. There are 2 of them, rosiglitazone and pioglitazone. In the United States, the only one that we have left is pioglitazone. Now, you can automatically see something very different. So I'm plotting for you here the change in hemoglobin A1C on the y-axis as a function of time. Now, the initial decline in the A1C may vary because the study design is very different. But whatever the initial decline is in A1C, you can see that that A1C decline persists. And it persists for upwards of 5 to 6 years. So I use pioglitazone as part of first-line therapy in all of my diabetic patients. There are lots of misconceptions about the thiazolidinediones, and maybe in the question and answer period we can talk about them. But because of these misconceptions, this class of drugs has not become as popular as it should be. Now, if the A1C comes down and it stays down, that should tell you that these drugs must have a very powerful effect on the beta cells. Now, what your professors are going to teach you is that pioglitazone and this class of drugs are insulin sensitizing drugs. And they are. They are the only insulin sensitizing class of drugs that we have. But in addition, it was very clear to us, if the A1C comes down and stays down, these drugs must also work on your beta cells to preserve beta cell function. So many, many years ago, we developed a technique called the insulin clamp technique. We're going to infuse insulin, and then using radiolabeled glucose, you can measure exactly how much glucose is taken up by all the tissues in the body. And we developed this technique in 1979, and today it still remains the gold standard for measuring insulin sensitivity. So the rate of insulin-mediated glucose disposal prior to starting the drug is shown in the yellow bar. The units are milligram per kilogram fat mass per minute of glucose taken up and metabolized. You can see that when I put you on pioglitazone in orange or rosiglitazone in green, there's about a 30 to 40% improvement in insulin-mediated glucose metabolism. So these are very, very powerful insulin sensitizing drugs. But more importantly, these drugs have a very powerful effect on the beta cell. So what I've plotted for you, and I'll explain it in, but what you need to remember is what's plotted on the y-axis is the gold standard for beta cell function. You can't do this in your practice. There are only a few research institutes, including ours, that can make this measurement. So we're going to give you a glucose tolerance test, and then from measuring insulin and C-peptide, we're going to calculate the insulin secretory rate. That's the IRS. And then during the OGDT, there's a rise in glucose and there's a rise in insulin secretion, and we're going to plot that ratio on the y-axis. But then your beta cells know how insulin sensitive or how insulin resistant you are, and they'll respond to, if you're very insulin sensitive, they make less insulin. If you're resistant, they make more insulin. So you have to bring the individuals back, and on a separate day, you measure their insulin sensitivity. What's plotted is called the disposition index. And this, as I said, is the gold standard for measuring beta cell function. So if we take drug-naive patients and we put them on placebo, you can see the yellow bars, nothing happens to your beta cell function. If I put you on pioglitazone, I triple your beta cell function. That's phenomenal. At rosiglitazone, I increase your beta cell function by 2.5-fold. So the reason why these drugs are so good is because they, number one, improve insulin sensitivity, and number two, they improve your beta cell function. So if we come back to the ominous octet, and we look at where these drugs work, lower left, they're very good insulin sensitizers in the liver. Lower right, they're very good insulin sensitizers in the muscle. Upper right, they're very good insulin sensitizers in the fat cell. Upper left, they have a very powerful effect on your beta cell to improve and maintain the improvement in beta cell function. Now, this class of drugs are also very cardioprotective. So the very, very first cardiovascular intervention trial was called the PROACTIVE study. It's a very large study done in Europe, 5,238 individuals. To get into this study, you had to have a myocardial infarction or stroke. You had to have a cardiovascular event. Half of the people are going to be placed on pioglitazone, and the other half of the people are going to be placed on placebo. And this shows you the Kaplan-Meier plot to what's called the MACE endpoint. MACE stands for Major Adverse Cardiovascular Events. There are 3 of them. It's cardiovascular death, non-fatal MI, non-fatal stroke. So in the United States, in Europe, worldwide, if you want to get a drug approved by the Food and Drug Administration or your agency that approves drugs for a cardiovascular indication, you have to show a benefit on the MACE endpoint. And in this study, pioglitazone decreased the hazard ratio to 0.84. So there was a 16% decrease in the MACE endpoint, and this was statistically significant. Now, in the PROACTIVE study, if you had a stroke, recurrent stroke was decreased by 47%. Pioglitazone is far and away the best treatment that we have for stroke. It's better than aspirin. It's better than dual antiplatelet therapy. If you do a carotid endarterectomy and I put you on dual platelet therapy, pioglitazone is more effective than the standard, quote, therapy for prevention of stroke. So a good friend of mine, Dr. Kernan, who's a neurologist, and Dr. Inzuccio, went to the National Institutes of Health in the United States and convinced them to do a large study. You can see 3,800 individuals. To get into this study, you had to have a stroke or a transient ischemic attack, TIA, within the preceding 6 months. But importantly, you could not be a diabetic. So this is a study in people who had a stroke who did not have diabetes. And you can see that the mean hemoglobin A1C is 5.8. To make the diagnosis of diabetes for the students, your A1C has to be 6.5. Prediabetes is an A1C 5.7 to 6.4. So half of these people had prediabetes, half of them had normal glucose tolerance. The results I'm going to show you didn't make any difference whether you had prediabetes or you had perfectly normal glucose tolerance. These people were then placed on pioglitazone or placebo, and then they're going to be followed up for 4.8 years. So here now you can see the Kaplan-Meier plot for a recurrent cardiovascular event, meaning stroke or myocardial infarction. And now you see that the orange curve with pioglitazone sits above the yellow curve. And what's plotted on the y-axis is the probability of disease-free interval. So the hazard ratio is 0.76, means there was a 24% reduction in recurrent strokes or recurrent myocardial infarction in individuals who are not diabetic, okay? So that means that the drug is working independent of controlling the A1C of the glucose. So pioglitazone has very powerful anti-atherogenic effects. It's a great insulin sensitizer. It's very good at saving your beta cell, and it's very good at preventing heart attacks and strokes. And for all of these reasons, I use it as part of my first-line combination therapy. Let's now talk about the incretin hormones. So when you ingest a meal, you always release more of these incretin hormones than if I were to give you the glucose intravenously. So I raise the glucose by the same amount orally or intravenously. You will make a lot more insulin when you ingest the glucose compared to when I give you the glucose intravenously. This is referred to as the incretin effect. And when you ingest the glucose, you're going to release 2 incretin hormones, glucagon-like peptide 1, GLP-1, and glucose-dependent insulinotropic polypeptide. Those two incretin hormones account for 70% of the insulin that you release in response to a meal. So what goes wrong in a person with type 2 diabetes? Your beta cells become very, very resistant to GLP-1 and GIP, and therefore the pharmaceutical industry has gone forward and has developed very, very powerful analogs of these peptides that will overcome the insulin resistance at the level of the beta cell and markedly increase insulin secretion. So we have a number of them. The first one that was introduced into the US market and the worldwide market is exenatide. This was called Byetta. It's short acting. You have to give 2 injections per day. And I was fortunate to direct these studies, and I'll show you them in a second. Subsequently, we had liraglutide. This was an injectable that you could give once a day. Then we had the long-acting GLP-1 analogs, such as dulaglutide and semaglutide. And each sort of 5 years, we have a new one that comes, and these are phenomenal drugs. So the very worst one, which is exenatide, I would characterize as a fantastic drug. So remember that. The worst one is a fantastic drug. And exenatide is really quite cheap. All of our patients should be able to afford it. Then the next one, which let's say is dulaglutide, this is a phenomenal drug. So we're going from fantastic to phenomenal. The next one is semaglutide. This is an out-of-space drug. Only a few people have gone out of space. And the most recent one is called Mounjaro. This is the one that goes to the dark hole, the black hole. No one has been there before. So these drugs go from fantastic to literally out of sight. And there are even better ones to come. So rituximab looks much better than Mounjaro and CagriSema. So when we think we have the best one, just wait a couple of years. There's a new one that comes will be much better. So why are these drugs so good? Well, first of all, they bind to the beta cell and they have a huge effect to kick out insulin. And not only do they make your beta cells make more insulin, they preserve the beta cell function on a long-term basis. So they're very effective at lowering the A1C. They inhibit glucagon secretion, which is important because glucagon is driving hepatic glucose production. They're very good at promoting weight loss. You can get with the newer drugs up to 15 to 20% weight loss, which is fantastic because most of our diabetic patients are overweight. As I'll show you in a moment, they correct 6 of the problems in the ominous octet. They do not cause hypoglycemia. They have a very good safety profile, and they also give us cardiovascular protection. So these are the initial studies that were carried out with Byetta. And all of the studies were conducted in a very similar fashion. So we could add Byetta to drug-naive patients. We could add it to people who are on metformin, people who are on sulfonylureas. So for the first 30 weeks, you get placebo. You can see nothing happens to your A1C. If I put you on the Byetta, there's a nice drop in A1C of about 1 to 1.2% if your starting A1C is 8. At 30 weeks, the people who are on placebo now have Byetta added, A1C comes down, the other group stays on Byetta, and then these studies were carried out for an additional 3.5 to 4 years. Very nice drop in the A1C, and it stays down. This is a phenomenal response because we're getting good glycemic control and we're preserving your beta cell function. So how does this happen? These drugs work through the cyclic AMP system, very different from the way glucose works. There's a gene called PDX1, which is critical for the health of your beta cells. And in people with, excuse me, people with type 2 diabetes, PDX1 doesn't function very well. And this class of drugs upregulates PDX1. And there's a marked decrease in beta cell sensitivity to glucose because there's a downregulation of GLU2 and glucokinase. These drugs upregulate those 2 genes. And we also know that beta cells die progressively, and these drugs preserve beta cell function by stopping beta cell apoptosis. So this is a fantastic class of drugs for treating our diabetic patients. So let's look at two of the newer ones, semaglutide and dulaglutide. On the left-hand side, you can see the A1C. The drops are 1.8, 1.4. A little bit of a difference, but they're still phenomenal. If you look at weight with semaglutide, they lose anywhere from 5 to 8% of their body weight, a little bit better than dulaglutide, but still very impressive. Here's the more recent one, tirzepatide. This is Mounjaro. This is a dose response study going from 5 to 10 to 15 milligrams. And on the left-hand side, A1C is 2.5. So if you're starting A1C is 8.5, for the first time, half of the people can actually end up with a normal A1C. This has never been achieved before with any other medication. And if you look to the right, as you go from the 5 to the 10 to the 15 milligram dose, we get up to 10 to 15% weight loss. Semaglutide is shown in orange. We still, even with semaglutide, we're seeing 5 to 6 to 7% weight loss. And the newer drugs are actually causing up to 15 to 25% weight loss, which is very similar to what we see with bypass surgery. So let's come back now to the ominous octet. So you can see these drugs overcome the defect at the level of the gut because I give you a pharmacologic dose of the GLP-1. In the upper left, we markedly improve insulin secretion, beta cell function. We inhibit glucagon secretion. The increase in insulin and decrease in glucagon shuts down hepatic glucose production. These drugs shut off your appetite. And when you lose weight, we improve insulin sensitivity. They are not true insulin sensitizing drugs. Indirectly, we improve insulin sensitivity through the weight loss. Now, what about cardiovascular benefit? From left to right is liraglutide in the LEADER study, semaglutide sustained 6, Bydureon in the EXCEL study, and dulaglutide in the REWIND study. In all of these, you can see that the orange curve is below the yellow curve. They all cause cardiovascular protection, and they're approved by the Food and Drug Administration for reduction in cardiovascular event in our diabetic patients. The DPP-4 inhibitors are drugs that increase your GLP-1, and they increase it, unfortunately, only a little bit. More importantly, they prolong the half-life of GLP-1. And because they prolong the half-life, that's good. But because they only cause really a quite modest increase in GLP-1, they're not nearly as effective as the GLP-1 receptor agonist. I could show you many of the drugs. I've just chosen one of them, and that is saxagliptin. We have sitagliptin, litagliptin, etc. But you can see if I add it to drug-naive patients, yellow, I add it to a person on a cell phone, urea, glyburide, or metformin, the drops in A1C are about 0.7 to 0.8. With the newer GLP-1 receptor agonists, you get drops in A1C that are 2 to 2.5. So these drugs are effective, but on a long-term basis, they don't preserve your beta cell function. And as I showed you in the GRADE study, on a long-term basis, they fail. Now, what about cardiovascular intervention? So there have been cardiovascular intervention trials carried out with all of these drugs, and you can see it doesn't make any difference. I don't have to tell you who is placebo and who is drug because the two curves are identical. There's no cardiovascular benefit from these drugs whatsoever. Unlike the GLP-1 receptor agonists, which I show you are very powerful in terms of cardiovascular prevention. SGLT2 inhibitor class of drugs. So I actually invented this class of drugs many, many years ago, but unfortunately didn't patent this class of drugs. If I had patented them, I would not be flying economy class here and there. I would have my own plane flying wherever I wanted to fly. So the pharmaceutical companies have made billions of dollars off of this invention, but they still don't give me a first class ticket, just an economy class ticket. Thank you for getting me here on a business class ticket. I appreciate that. So there are a number of them that have been approved, and they work in a very different mechanism. That threshold for spilling glucose into the urine, which is elevated in people with type type 2 diabetes, they lower that threshold. So this is a new defect in our diabetic patients that's corrected by this class of drugs. You spill the glucose in the urine. We also showed that many years ago, high glucose poisons your beta cell. High glucose makes your muscle resistant to insulin. So the glucose spills out in the urine. Very simple idea. Unfortunately, no one thought about it until I came up with this idea and developed a drug that worked. As the glucose comes down, I improve your beta cell function, and I improve insulin sensitivity in muscle. Nice drop in A1C. And the left, because you lose calories in the urine, you lose weight. And people usually lose about 2.5 kilos in the first 6 months of therapy. And because the drugs work on the kidney, you can combine them with any other drug and get an additive effect. SGLT2. S stands for sodium, GL for glucose, T for transporter. These drugs block the SGLT2 transporter in the kidney. So I block glucose reabsorption, I block sodium reabsorption. So I put you into a little bit of salt and water negative balance. So we also get a very nice reduction in blood pressure. And these drugs have the additional benefit is that they don't cause hypoglycemia. So we're correcting a number of factors that should also not only lower glucose and prevent microvascular complications, but prevent macrovascular complications. So how do these drugs work? Okay. So these are the original studies that carried out. And for the medical students, hopefully you learned this in your physiology course. I'm sure since you're here, you passed the exam, but you probably thought it wasn't important and forgot it, okay? So now I'm going to bring this back to your memory bank. So what you learn in the basic science actually is important when you start to take care of patients. So this is what I referred to before as a renal glucose titration curve. So what I'm going to do is I'm going to infuse glucose, and I think this pointer's not working, but I'm going to raise your glucose from 100 up to 180. And on the y-axis, I'm going to plot how much glucose comes out in the urine. You see there's no glucose in the urine. But what happens when your glucose gets to 180 and I continue to raise the glucose, all of the glucose spills out in the urine, and that curve goes up dramatically. And this is you and I, we have an A1C that is, you can see at the top, 5.0. So here's a person with type 2 diabetes, A1C 6.5. This is the diagnostic criteria at which type 2 diabetes begins. Well, you can see the threshold for spilling glucose is now 205. Now, here's a diabetic who's a little bit worse controlled. A1C is 7.5. That threshold is even higher, up to 220. If your A1C is 8.5 or 9.5, you can see the threshold for spilling glucose now is up to 260. So as a physician, we want the diabetic to dump the glucose into the kidney and out in the urine. Instead, a paradoxical signal goes to the kidney. Let's hold on to the glucose. So how do the SGLT2 inhibitors work? So this is what a normal titration curve looks like in your eye. The threshold is 180. Diabetic schematically is increased. When I put you on the SGLT2 inhibitor, how low do I lower your threshold? Do I lower it back to 180? Nope. Do I lower it to 100? Nope. I lower the threshold to 40. That means that if I give these drugs to anybody in this room, over the next 24 hours, you're going to spill 60 or 80 grams of glucose in the urine. There is no such thing as a non-responder from a diabetic standpoint unless they have severe renal disease. So this is going to be a very good drug for treating our diabetic patients and lowering the glucose. Now, if we come back to the ominous octet, the primary mechanism of action is on the kidney at 9 o'clock. You're going to dump glucose out in the urine. And as the blood sugar comes down, I improve insulin sensitivity in muscle. So it's an insulin sensitizing drug indirectly. And then in the upper left, I get rid of glucotoxicity at the level of your beta cell. I improve your beta cell function. Now, what about these drugs in cardiovascular disease? This is the original study with empagliflozin, and going from left to right is the effect on the MACE endpoint, major adverse cardiovascular event. Combination, remember, cardiovascular death, non-fatal stroke, non-fatal MI. Hazard ratio is 0.86, a 14% reduction in the MACE endpoint. Look at the middle panel. That's the effect of empagliflozin on death. Hazard ratio is 0.62, okay? 38% reduction in death. And in the right is heart failure. Hazard ratio is 0.65. So I like to joke. Look at that middle panel. If you don't like your diabetic patients, and we all have patients we don't like, don't give them the empagliflozin. They may die, okay? You'll get rid of them. But if you like your patients, and I like most of my patients, I like to keep them around. I put them all on empagliflozin. So this class of drugs I use as part of first-line therapy with pioglitazone and the GLP-1 receptor agonist. The other thing, the pointer, as I said, doesn't work. But if you look, these curves separate within 2 to 3 months. So the sooner you start the drug, the better your patients are going to be in terms of survival. Now, what about the SGLT2 inhibitors in diabetic kidney disease? Until the development of these drugs, the only drugs that we had for preventing kidney disease were the ACEs and the ARBs. So this was a new advance. So to the left is the Credence study done with canagliflozin. So to get into these studies, you had to have a significant decrease in the GFR and proteinuria. And then we're going to treat you with canagliflozin. This is the Credence study. And there's a combined endpoint, which is doubling of your serum creatinine, having your GFR, progression to dialysis, progression to renal transplantation. Well, you can see that within 8 to 10 months, these curves start to separate, and the hazard ratio is 0.66, a 34% decrease in ending up in dialysis or transplantation. And then in the right now is DAPA-CKD. Credence study was carried out in diabetic patients. DAPA-CKD was carried out in diabetic and non-diabetic patients. And you can see, again, the tremendous benefit. And it didn't make any difference whether you were a diabetic patient or a non-diabetic patient. The dapagliflozin actually prevented both diabetic and non-diabetic individuals from ending up on dialysis or transplantation. Now, until recently, the American Diabetes Association guidelines, which I actually have disagreed with, and I still disagree with them, have said that first-line therapy should be metformin. So these are the 2023 guidelines. And you'll notice that first-line therapy, metformin is not there anymore. Metformin used to be there. Now it says first-line therapy. So as you read from left to right, if you have atherosclerotic cardiovascular disease, first-line therapy should be a GLP-1 receptor agonist or SGLT2 inhibitor. If you have heart failure, first-line therapy should be an SGLT2 inhibitor. If you have renal disease, first-line therapy should be an SGLT2 inhibitor. So this is a major advance. But I have to tell you, this is 12 years behind time because we had these data 12 years ago. We have had 7 huge cardiovascular outcome trials and 7 huge renal outcome trials. And finally, thank the God, in 2023, the guidelines have changed, okay? But here's the problem. Only 15 to 20% of our diabetic patients have cardiovascular renal disease. So what are we going to do in the other 80% of our patients who don't have cardiovascular or renal disease? What's the role for the SGLT2 inhibitors, the GLP-1 receptor agonist, and pioglitazone? So now we have to go back to what the ADA algorithm tells us what to do in 2023. And in my opinion, the ADA algorithm is way behind time, okay? So now I'm going to start to fill in the missing information. The goal of therapy should be A1C less than 7. Now, we make the diagnosis of diabetes when the A1C is 6.5. So why shouldn't the treatment goal be 6.5? So I think 7 is too high for our diabetic patients. But that's a small objection I have. Here's the big objections, okay? So if you look at the drugs, except for the one to the far right, they say you can use them all with equal efficacy. And this is absolutely incorrect, okay? So GLP-1 receptor agonists first. I think that's great, okay? Then insulin. most of our diabetic patients don't want to be started on insulin as first or second line therapy. Metformin. I like metformin. Metformin's number 4 on my list of good drugs. SGLT2 inhibitors, yes, they should be in the first line. Sulfonylureas, they should be eradicated from this completely. They shouldn't even be up here. The only reason why you should be using sulfonylurea drugs is if cost is an issue and they can't afford any other drugs. These should be at the absolute bottom. Most common cause of hospitalization for hypoglycemia, sulfonylureas. And I showed you, after the first year, they don't work. TZDs, they should be there in the first line. And you see, they finally have recognized the DPP-4 inhibitors don't work as well as the other ones, and that's why they're set a little bit lower. So I like that they put SGLT2 and GLP-1 if you have heart or renal disease. I don't like the way they have this structure, okay? Now, if you understand what goes wrong in the diabetic, there's a holistic approach that needs to be undertaken. So when you see diabetic patients, you don't just have glucose and iron. You have the kidney to take care of. You have the heart to take care of. And now we know it's the commonest cause of end-stage cirrhosis, at least in the United States and worldwide. So, yes, when we pick a drug, we want the drug in the upper left to lower the A1C. But we want our drugs to have cardiovascular protective effects, like the SGLT2 inhibitors, the GLP-1 receptor agonist, pioglitazone. We would like them to promote weight loss. We would like them to protect against kidney disease, as do the SGLT2 inhibitors in a new study with the GLP-1 receptor agonist, the FLOW study. And we'd like them to prevent steatosis and hepatic fibrosis, NAFLD and NASH. And as I said, we should be really starting with combination therapy. Now, there are a number of combination therapies that you can use. I'm just going to show you 2. I'm going to start with the Duration 8. So Duration 8 is a 2-year study, and patients could be placed on either dapagliflozin, which is the pink to the right, on exenatide, which is the yellow in the middle, or they could be placed on combination therapy with exenatide and dapagliflozin. And we're going to look at the drop in A1C. So you get about a 1% drop, the pink, with dapagliflozin, a 1.3% drop with exenatide, and a 1.7% drop. You get an additive effect when you put the two together. Clearly, combination therapy is better. But here's what's really most important. So this is now cardiovascular outcomes. So I'm going to compare dapagliflozin alone to the both together, or empagliflozin alone to the both together. First, on a composite of cardiovascular events. It's a stroke, myocardial infarction, acute coronary syndrome, peripheral vascular disease. So if I put you on both drugs together, the hazard ratio is 0.76. You get a 24% benefit from both drugs together compared to either one alone. What about myocardial infarction? The hazard ratio is 0.71. So you get a 29% better effect in protection against heart attack with both drugs compared to either one alone. And then look at the one to the right. This is all-cause mortality, okay? Either dead or alive, okay? It's a pretty definitive endpoint. When I put both drugs together, I get 32% benefit compared to either drug alone. So clearly, you should be thinking about combination therapy with the drugs that give you cardiovascular protection. So we decided that we would do the definitive study that would show the world that the ADA and the ESD guideline for the treatment of diabetes is not the best guideline. So this is called the EDIC study, efficacy and durability of initial combination therapy in type 2 diabetics. And in this study, we took 318 newly diagnosed drug-naive patients, and we followed them for 3 years. These data are published. I'm actually going to show you the 6-year data. So we said one half of the patients will be treated the way the American Diabetes Association and the European Diabetes Association says you should be treated. We'll start you on metformin. And when you fail, and you for sure will fail, every study in the world has shown this after the first year, we'll add a sulfonylurea. And then when you fail, and you will, because every study in the world has shown you'll fail on a sulfonylurea, we'll add glargine insulin. And we'll titrate the glargine insulin up to 60 units. This is the standard approach. forgetting about cost, I understand cost is a big issue, okay? But what we want to know is what is the best treatment, okay? The second group is going to get triple therapy right from the beginning. They're going to get pioglitazone, they're going to get exenatide, and they're going to get metformin. So when we started the study, SGLT2 inhibitors were not available. So if they were available, if I did the study today, I would replace metformin with the SGLT2 inhibitor. Now, the endpoint of this study is not the hemoglobin A1C, because if your hemoglobin A1C got to 6.5, okay, you failed, you're out of the study. The endpoint is the percentage of people who at 6 years have an A1C that's less than 6.5. So once your A1C got to 6.5, you failed, you're out of the study. So your A1C really couldn't go very high. So here now are the 6-year data, okay? So you start with an A1C of 8.8. The conventional therapy, which is the ADA-EASD approach, it's not bad. The A1C comes down, okay? But then you can see in yellow, it starts to go up. And at the end of 6 years, the A1C is 6.9. But it can't go very high because once you get above 6.5, you're out of the study, okay? But still, if you look at the comparison between the two groups, it's 6.9 versus 6.1, and it's highly statistically significant. Now, here's the real endpoint of the study. It's the percentage of the people who have an A1C less than 6.5. So if you look at the ADA-EASD approach, that's the yellow curve. 71% of the people have failed, meaning their A1C is above 6.5. If you look at the approach that we're recommending, which is based on pathophysiology, 70% of the people have an A1C less than 6.5. This is total destruction of the ADA-EASD approach to treatment, okay? Which group would you want to be in? Do you want 71% failure, or do you want 70% success? Everybody who wants 71% failure, put your hand up. Why aren't you raising your hand? It's the standard approach. Who wants to be in the 70% success rate? Hands up. Okay, so everybody should be putting your hands up. Now, this is what works. I said you also have to take cost into consideration. And many of your patients are not going to be able to afford the newer drugs. So any therapy is better than no therapy. And for each patient, you're going to have to take cost into consideration. So why did our approach work? So from on the left, using very sophisticated techniques that I told you about, we're going to measure insulin sensitivity. So in our triple therapy, if you look at the two orange curves, light orange baseline, dark orange 3 years later, 6-year data are the same. I triple your insulin sensitivity. Look at the ADA approach in yellow. What happened to your insulin sensitivity? That's 0, okay? No effect whatsoever. Look at the panel to the right. What about your beta cell function? The triple therapy approach that we used is in orange. Light orange to dark orange. I normalize your beta cell function. I gave you a normal beta cell. Nothing does that, okay? Look at the conventional therapy, the ADA approach. What happened to your beta cell function? Nothing. So how do you think metformin self-following ureas, which don't improve beta cell function and which don't improve insulin sensitivity, is going to lower the A1C and keep it down on a long-term basis? That's why 70% of the people fail, okay? Now, this is not a cardiovascular outcome trial. You need 5,000 people for such a study. But we measured carotid intraluminal thickness, which is a surrogate measure of atherosclerosis. You can see in the triple therapy, no progression. In the conventional therapy, progression of carotid intraluminal thickness. So I know the people in the back of the room cannot read this. So this comes from the 2022-23 ADA standards of medical care. So I'm going to read it for you. So it says, because type 2 diabetes is a progressive disease, maintenance of glycemic targets with monotherapy is often possible for only a few years. The traditional recommendation is to use stepwise addition of medications to metformin. We already know that's going to fail. However, there are data to support initial combination therapy for more rapid attainment of glycemic goals and longer durability of glycemic effects. There are 2 studies only that are quoted. One is our EDIC study, and the other is the Verify study. So at least now, for the first time, there is a recommendation of starting with combination therapy. But interestingly, if you read these guidelines, there's nothing about pathophysiology. So the reason why our therapy works is we're correcting the underlying pathophysiologic defects. But at least we're making progress in terms of the recommendation and where we should be. So that's my final slide. I want to thank you very much for the invitation to be here and share this with you. And if we have time for questions and answers, I'm more than happy to answer them. Again, thank you very much. In the front row. Yeah.
Thank you, Professor. It's an amazing presentation. I want to ask that, I really wonder this. By the way, I'm a pharmacologist, so I really wonder that. You know, liraglutide is a very important molecule for us. And also in Turkey, we know that in a commercial name is Saxenda. And the other name is Victoza, you showed us. Yeah. And in this liraglutide molecule, it's a 6 milligram. It's enough to control for the glycemic index. We can use this for anti-diabetic agents. But also in Turkey, we use this agent for the obesity control.
Very good.
Yes. So, yes, all the drugs has a, you said to us, any therapy is better than no therapy. So all the therapy has a advantages and disadvantages, and liraglutide also. We know that in some studies show that liraglutide causes pancreatitis. So it's too risky to us. For that reason, for our patients, what is your advice? Yeah. If a patient don't have any comorbidities or a serious disease, what is your really the first line therapy? Yeah. I really wonder this.
Yeah, so you need to understand that pancreatitis is a very, very rare complication. It's like 1 in 2,500 individuals may get pancreatitis. So it's incredibly rare. So the standard recommendation is don't worry about pancreatitis unless the patient has a history of pancreatitis. So if the person has had a history of pancreatitis, we don't use the GLP-1 receptor agonist. Now, I have to say that if you look at the newer ones, the incidence of pancreatitis is actually no different from the placebo. And so there is maybe with liraglutide, maybe a little bit of a difference. But with the other ones, yes, there's a warning that's in the package insert, but it's, in my opinion, so rare that it should not be a reason for not using the drug. And even if the person has had pancreatitis, say, due to a gallstone, and now I remove the gallstone in the gallbladder, is taken out, I still use the GLP-1 receptor.
But you said to us all comorbidities or all side effects, we have to prevent all of the all causes of mortality. So, okay, I can prevent cardiovascular disease and the other risk, but it's also a risk for me. I don't want to take for this for my patients.
Well, if you look at number needed to treat for a heart attack or stroke, I'll kind of put it into perspective for you. You need to treat 20 people to prevent a heart attack, stroke, or death, okay? You need to treat 2,500 people to maybe see 1 case of pancreatitis, okay? 20 versus 2,500. Pancreatitis, I can treat.
But it's for now.
You're
because
dead,
it's a new molecule.
I'm sorry?
It's a new molecule. For now, it's a rare side effects, but in future, we don't know.
Oh, we do know, because liraglutide has been on the market in the United States for about 12 years now. And all of the other GLP-1s have been around for at least that period of time. And as I said, with the other GLP-1 receptor antagonist, you can't statistically even demonstrate an increased incidence of pancreatitis. So even though there's a warning, and again, as I said, if you have a history of pancreatitis, we don't recommend that you use the drug unless it's something that's been correctable. To me, the liraglutide data are the unusual. And there it's like one case in 2,500. And pancreatitis, yes, it can be fulminant, but in general, it's not a fulminant disease. Okay, death, you don't come back from death. Okay, so, you know, it's 18 to 20 number needed to treat for death, MI, stroke, versus maybe 1 in 2,500 for pancreatitis. I think the benefit far outweighs the risk. Every drug that we use has a side effect. But here, I mean, we're talking about death, stroke, myocardial infarction versus pancreatitis, and the numbers are way, way in favor of the GLP-1.
Thank you so much,
Yeah.
Professor.
Other questions? Is over on the right-hand side. Yes. Young lady and a young man.
Test. Okay. Thank you again for the very informative presentation. I was just confused about one little thing. At the beginning, you told us about metformin. I didn't quite catch why you would not recommend metformin. Like, you've counted a lot of disadvantages, but yet it's used again. So I wanted to ask, why is it used commonly?
So I didn't say you shouldn't use metformin. I say it's number 4 on my list of good drugs. So the top 3 drugs that I use in my practice, and I use them in combination, are GLP-1, pioglitazone, SGLT2 inhibitor. The 4th good drug is metformin. It's number 4 on my list. And in many of my patients, I practice at the university. We see all the rich patients, okay? They can afford all the new drugs. The other institute is the Texas Diabetes Institute. 80% of my patients are below the poverty level. So there, I very commonly use metformin because they can't afford the newer medications. So pioglitazone in the United States, very cheap, $5 per month. Metformin is very cheap, $5 per month. Exenatide by Durian, it depends, the copay is between $15 and $25 per month. So those drugs, even where I practice where the people can't afford them, they can afford those 3 medications. On the other side of the street, they can afford the newer medications, so I use the newer medications. The fact is, worldwide, number 1 prescribed drug is metformin. Number 2 prescribed drug is sulfonylurea. Number 3 prescribed drug are DPP-4 inhibitors. Number 4 prescribed drug is insulin, okay? That's basically a cost issue, okay? In terms of efficacy, and you need to understand the difference. What are the best drugs? Which ones work, okay? You may not be able to use them. So for each patient, you have to make a decision. I hope you know now what are the best drugs, but you may not be able to use them in some of your patients.
Okay, so in conclusion, metformin is used so commonly because it's so easily available and so cheap for most patients. And as you said, any therapy is better than no therapy.
Yes, you could give this lecture now. It was perfect.
No, it's because you did it so well. Thank you again.
So don't anybody go home saying that Dr. DeFronzo said metformin is a bad drug, okay? It's a good drug. It's just number 4 on my list of good drugs.
I just wanted to clarify.
You got it
Thank you.
perfectly. Yes.
So thanks for your speech. I wonder your idea about the anticholinergic side effect of metformin.
Side effects.
Yes, as a side effect, anticholinergic power of metformin. As I know, anticholinergic power can induce such a serious side effect.
Yeah, this is not a side effect of metformin. The major side effects of metformin are GI, nausea, diarrhea, and worldwide, about 15% of people cannot tolerate metformin because of the GI side effects. even at low doses at 1,000 milligrams. But that's the major side effect. It can interfere with vitamin B12 absorption, but B12 anemia with metformin is really quite uncommon. Usually you'll be checking the hematocrit anyway annually in patients. If you see the hematocrit drop in someone who's on metformin, you should be thinking about checking the B12 level. But that's a very, very uncommon side effect. The most common side effect, as I said, are GI. Nausea when you start, diarrhea, 15% of the people cannot tolerate it. And that's pretty consistent whichever country you live in. Yep.
Thank you, doctor. Welcome, Turkey. I am Dr. Mustafa Kalaycı from surgery unit. What is your opinion about the pre-diabetes weight loss control for diabetes, about the obesity surgery?
Yeah.
And then I'm wondering, what is your opinion about microplastic interaction with the obesity control and the drug resistance study? Thank you.
Well, let me answer the first one, and then I'm not sure I understand the second question, but let me answer the first question. So he's asking about bariatric surgery, and there are two types of surgery: the sort of room-wide bypass procedure or the sleeve gastrectomy. They are both incredibly effective in treating diabetic patients. So anybody who has morbid obesity should, in my opinion, have bypass surgery. And I think as we've come into the modern ages, the sort of BMI index has gone down. So if you have a BMI of 35 and one cardiovascular risk factor, then you should seriously consider the surgical procedures. And I would say even in people who have lower BMIs, say, 28 to 32, if you have very difficult to control diabetes on a very high dose of insulin, I think you should also consider the bypass surgery in those people. It is very clear. It's incredibly effective in controlling the A1C. The long-term data show cardioprotective effects. They also show renal protective effects because of the glycemic control. But people need to remember that just because you have the bypass surgery, you can't forget about diet and lifestyle, because people after 5 to 10 years, if they abuse the diet, they can regain weight and the diabetes can come back. So I use it not uncommonly in my patients. Now, I have to say, though, with the newer drugs, Mounjaro, as I said, the weight loss is 15 to 20%. And with the new Lilly drug, which is retatrutide, the weight loss is 25 to 30%. So in Cargi-Sema is also 25 to 30%. So these newer drugs are now getting to the bypass surgery type level. But they're very expensive. As I said, $1,200 a month, many patients can't afford this. So I think there'll always remain a place for bariatric surgery. And it works. I'm sorry, repeat the second part of the question for me.
Especially microplastic interaction about the diabetes and pre-diabetes patients, or the microplastic interaction with the drug therapy.
What do you mean by microplastic?
Microplastics is effect on the obesity effect on diabetes, the mice on the experimental studies. Did you have any idea, or can you give some? Excuse me.
I'm not sure I understand the question, but I'll try to answer it. So we showed many, many years ago, when you gain weight, okay, and you put fat in muscle, it makes muscle very resistant to insulin. I can explain to you the molecular basis of this as well. You put fat in your beta cells, you impair beta cell function. You put fat in your liver, you get steatosis and cirrhosis. This is a term we call lipotoxicity. And if you get people to lose weight, it doesn't make any difference whether it's bypass surgery or whether it's drug, and you mobilize fat out of tissues, you will improve beta cell function, you'll improve insulin sensitivity. So quite frankly, the best treatment in the world is weight loss. And if we could get people to stop eating, and you know, you don't have to pay for the extra food, so they save money. They lose weight, everything gets better. They don't have to be on their drugs. But it's difficult to get people who, on a long-term basis, to lose weight and keep it off. And people need to understand that obesity is a disease. You are resistant to GLP-1. You are resistant to amylin. You are resistant to PYY. You are resistant to leptin. You have all of these hormones that are driving you to eat. So when you go to see the dietitian and the dietitian puts forward a recommendation, it's difficult for the patient to outthink the physiology that's going on. So in addition to diet therapy, we're going to need pharmacotherapy. And it works. These newer drugs are incredibly effective. And we understand why they work in terms of mobilizing fat out of tissue. And when you get fat out of arteries, I protect you against coronary artery disease. So weight loss is the best treatment in the world. If you ask me to pick one drug instead of the triple therapy, I would pick a GLP-1 receptor agonist as the one drug because it corrects 6 of the problems of the ominous octet. And that is the most effective single drug therapy. But again, they're expensive. In the United States, by Durion, exenatide will be going generic in about 3 years. So this is a very good drug. It's one of the fantastic ones. It's not the outer space one, but a fantastic drug is still fantastic. Question in the back of the room.
First of all, welcome to Turkey, and thanks for your wonderful speech. I was asking that you said that GLP-1 receptors agonist and SLG inhibitors, they causes weight loss. I was asking that, are there any decrease in muscle mass?
Yeah.
And if it is, how can we prevent that? Or do we see any muscle skeleton disabilities or not?
Yeah. Oh, so you're a very smart fellow. So this is one of the things that really has not been examined. And we actually have a study that's going on. No one has ever measured muscle mass or frailty, okay, weakness. And remember, a lot of our diabetic patients are older. And if you lose 20% of your body weight, of course, you're losing, you would be expected to be losing muscle mass. So people have said that the lean body mass decreases in proportion to the total weight loss. The problem is lean body mass is bone mass, it's fluid, it's interstitial tissue, and it's muscle. So even though there's a proportionate decrease, of course, if you're carrying less weight, you need less muscle. No one has actually measured muscle mass, never been measured, and no one has actually measured frailty. And I think this is a potential concern. The other issue that's never been looked at is what happens to bone mass as well. So these are, particularly with the newer drugs, you start losing 25 to 30% of your body weight. I think we need to pay more attention to these potential side effects, particularly in an older population. So that's a very insightful question. We don't know the answer to that. Yes.
Beyza from Medicine Faculty. Thank you for your presentation. We are so pleased to have you here. According to European safety analysis of mRNA and viral vector COVID-19 vaccines on glucose metabolism events, the mRNA vaccines were associated with increased frequency with type 1 diabetes, type 2 diabetes, and high glucose levels. So now, too many people vaccinated with those vaccines in the world, like 2 or 3 times or even 4 times, should be aware of this. And do you think in near future, do we have so much people with diabetes, like much with diabetes people around here? Or for young population, is this a risk for near or further future? Thank you.
Yeah. So this is an interesting and controversial topic. So basically, she's saying with the COVID epidemic, initially there was a report came from the United Kingdom that there was a large increase in type 1 diabetes. And the virus clearly can affect the pancreas. However, over the years, there have been many, many additional studies, and those UK data have really not been borne out. So I don't believe that there's an increased incidence of type 1 diabetes in people who have been infected with COVID. Now, type 2, that's now even more controversial. So we're part, I have a large NIH grant, it's called Recover. We're looking at 2-year follow-up of people who were infected with COVID and were in an intensive care unit. So they're severely ill people. And comparing them to people who came to our hospital with a viral infection that turned out to be COVID negative. So this is a long-term study to try to define whether there is an increased incidence of type 2 diabetes. And again, there have been reports say that, yes, there is an increased incidence 2 years later. There are other reports that say not. So I would say that's still an unanswered question. I think the data on type 1 say that there really is not an increased incidence of type 1. But we don't know the answer in type 2. Long COVID is mostly neurologic symptoms because the COVID gets into the central nervous system. And clearly there, the neurologic systems can, and there are a variety of them, can persist for upwards of 2 years. Diabetes, I'd say we don't know the answer to that yet. So it's a good question. Unfortunately, we don't have enough data to answer it definitively. Other questions? Okay, I will be around. Oh, yes. Here, yeah.
Again, just from a simple observation standpoint, I was just wondering, you've mentioned that weight loss is an awaited goal. So I was wondering, patients that use steroids because of the various diseases, would it counteract against the goal of losing weight with the medicine given? Would the patient stay at the same weight they have achieved, or would we treat it differently?
Yeah. So steroid-induced diabetes is complicated, and you also get weight gain. And if you look at typical people with Cushing's disease, take the extreme example: puffy faces, central obesity, muscle wasting, leg wasting. So steroids put fat where it doesn't belong, and they tear down your muscle. In addition, they cause insulin resistance in skeletal muscle, and they impair beta cell function. They impair beta cell function by inhibiting the Wnt signaling pathway, W small nt. The GLP-1 receptor agonists specifically block the effect of steroids on the Wnt signaling pathway, which is the major reason why you develop diabetes. It's not because you become insulin resistant. And steroids, as I said, they do both. They make you insulin resistant, they cause beta cell dysfunction. GLP-1 will block all of the effect on the beta cell. And in fact, in my opinion, the best way to treat people in the hospital for glycemic control rather than intensive insulin therapy in the ICU, because you don't get hypoglycemia with GLP-1. In terms of whether it would redistribute the fat from what steroids do from centrally to more peripherally, there's never been a controlled study to look at that. But in terms of preventing steroid-induced diabetes, they're very effective in doing that.
Thank you once more.
Yeah. Okay, well, I will be around for a while if there are additional questions. Is someone, yeah.
Thank you for your nice presentation. I'm from the Department of Physiology. I would like to ask if sodium glucose transporters are only localized in your drugs to affect on the kidneys, or also they also have effects on the small intestine?
Yeah. So SGLT2 transporter is literally entirely located in the kidney, in the proximal tubule. The SGLT1 transporter, that's the one that's in the gut. And the original work that I did actually was done with fluorescein. which is a combined SGLT2, SGLT1 transporter. And if you block SGLT1, in addition to blocking SGLT2, that's very effective. The problem is you can't block the SGLT1 transporter sufficiently in the kidney without blocking it in the gut and getting severe diarrhea. So a number of companies have tried to do this, and they've all failed because of the GI side effects. Canagliflozin has a little bit of SGLT1 inhibitory effect, as does sotagliflozin, but there's so little SGLT1 inhibitory effect that if you look at the A1C drop, it's really not too much different from what you see with a pure SGLT2 transporter. Yep, in the fourth row back.
Thank you. It's a short question. Some of anti-diabetic medication induce cancer. For example,
Induce
cancer,
what?
yes, bladder cancer, as I remember. So I think your opinion.
They induce, I'm not sure what you, induce what?
Cancer, bladder
Oh,
cancer,
bladder
for
cancer.
example. For
Yeah.
example.
Yeah, I got it. Okay.
And also the other molecule have this kind of problem. So the rate is very low. But for example, 20 years later, the patient come and your drug induce cancer, and it might be a problem of malpractice. What is your opinion?
Yeah.
Thanks.
So this is one of the misconceptions that has been generated with bladder cancer. So when Takeda Pharmaceuticals in the U.S. was developing pioglitazone, they were required by the FDA to do a long-term study with pioglitazone. The study was done in California at Kaiser Permanente Northwest. It's a huge long-term study. The hazard ratio for bladder cancer is 0.98. You know what that means? No bladder cancer. So this is another major misconception that exists with pioglitazone that does not exist. So in my opinion, pioglitazone does not cause bladder cancer. There's another misconception that it actually has negative effects on the heart. In my opinion, that's totally wrong. The pioglitazone, it actually, everything that it does to the heart improves cardiac function. So there are a lot of misconceptions about pioglitazone. If you want, I've written a very nice article on this. It's in one of the cardiovascular journals about 3 years ago. You can Google my name, and it goes through the effects on the heart. It also will give you the references in terms of bladder cancer. So in my opinion, that really is a misconception. But it is something that is in people's mind. It's out there, and it has, I think, limited, one of the reasons why the use of the drug has been limited, unfortunately. Okay. I think there's one. Yeah.
Doktor DeFronzo ilham verici konferans için teşekkür ediyorum ve plaketini takdim etmek üzere mütevelli heyeti başkanımız Prof. Doktor Yusuf Ergörmüş'ü sahneye davet ediyorum.